So, ACL injuries and return to play guideline is something I would chose as my topic for my internship experience at NYP. My name is Marcus Escondido, and these were often common for me to see. And what I mean by that is that more often than not, late in the afternoon when I did my internship from 12 to 8, I would see kids, high school kids, coming at like 5 or 6, when I would assume they would be coming off of their practice or schoolwork. Well, usually the school starts like 7 and ends at 3, as I remember when I was in high school. And this was an outpatient clinic, so most of the patients have already pretty much recovered, or they were referred by their healthcare provider because they are getting some pain associated with the injury, even though they recovered, and they might want to go back and play. Mechanically, these ACL injuries can be characterized in two groups: contact and non-contact. Contact basically is an extensive tension force applied to the ACL. Non-contact happens when a athlete, decelerates really, really quickly, way too fast. So suddenly jumping or stopping from going to a dead nothing after sprinting will cause that to happen. They're more likely to cause that injury. And these usually happen with sports that are classified as high-impact rotational landings, or they have high-impact rotational landing, which is like self-explanatory. So soccer, football, basketball, those type of sports where you're often seeing that these athletes suffer an ACL injury, right? And with regards to age and gender, females are more likely to suffer ACL injuries compared to the boys when participating in recreational sports. The only exception to that is the fact that a study found that prepubescent males are more likely to suffer from ACL injury due to their increased participation in recreational sports. Most likely, them running, playing tag, getting the activity out because they have a lot of energy when they're young. So they're gonna keep moving around and more likely gonna mess up and have themselves an ACL tear. Studies found that usually there is a chance for re-injury, and that's 1 out of 5 people. But if that doesn't happen, there's a 65 to 88% chance that the athlete can return to the sport within a year, given they had the right treatment and rehab, and they got the green light from their healthcare provider. Main concern, though, with the physician is, while they may be able to give them that rehab, their concern might be if they have long-term knee health as a concern, that they want to maintain that knee for the way it is even after the injury, is it even worth to participate back in the same sport? Because there's a chance, like I said before, that they could re-injure it and make their situation even worse. Now, if the athlete does want to go through and put their knee to the test and chance it, they have to do some tests. One being the hop test, where they can the physical therapist asks them to hop a certain way, in which they can determine the knee's dynamic stability. And these tests are conducted 12 weeks after the ACL reconstruction. The injured quadricep is going to be evaluated compared to the uninjured one, meaning the quadricep strength index is going to ask, they usually see that they need to have 80% worth of strength compared to the uninjured limb. They need to have 80% in the injured limb for them to even conduct this test. After the tests are conducted, the physician's going to advise the athlete to strengthen that injured quadricep to at least 90% before they can be okay back into participating in recreational sports. With ACL injuries, it's safe to assume that they're going to need a long time to rest. If it happens, you need surgery, you can't move because you tore your ACL. Because of that, there's going to be some muscle atrophy, which is why I was referring to the strength index, because it's assumed that your muscle is going to atrophy if you're not doing anything because of the injury. And so to combat this, or to get the quad activated without using or causing a change in the range of motion, they use stem pads or neuromuscular electrical stimulation. And specifically, they use it on the Russian stem, which uses monophasic and biphasic. Monophasic sends the current directly one way, and biphasic sends it both ways. This is just so that it can help promote combat muscle atrophy and it helps with keeping type 2 muscle fibers less atrophied, and type 1 muscle fibers, they maintain their contractibility, meaning the muscle memory might be there and they could go back to what they were before the injury, or closest they can before the injury. So at my internship, I saw several treatments. Now, while not for an ACL injury, I did see deep transverse friction massage. So they would imagine this is the knee, and above here is the quadricep with the tendon, and then the knee is right here. They would, if the muscle fibers are going like this, I was told they would rub against the skin like that to help promote blood flow, so that they could possibly help the tissue that got injured. And this was from a study from when a female football player had a medial meniscotibial ligament injury, which is not the same as an ACL, but it still happened while she was playing in participating in recreational sports. Another treatment I saw was the Graston, or instrument-assisted soft tissue manipulation, which is a piece of metal that the physical therapist uses that has a beveled edge, which lets them deeply massage the tissue in a way that's not like they can use with their hands. It usually helps them save their joints as well. And there's certain ways you can hold it. If you hold the angle, if you hold the Graston like this, and the tissue's like that, and you go like that, it's going to cause a much more intense feeling as opposed to where you put it like that. And this could be related. They bring this up because some patients can handle the Graston there, some can't. They prefer it with less pain. It's all up to the patient. And these Graston treatments, massages, can help increase the range of motion and functionality of an ACL injury while decreasing pain. Well, with the Graston, they also need to use a certain cream called Deep-Prep 2, which essentially helps them prevent a skin abrasion, because it's assumed that if you're going to keep going like this, it's not going to feel great on the skin. It's just skin on skin, or metal on skin. It's not fun. You need to have some sort of cream to help make sure that you can properly massage the patient without causing them to have a skin abrasion. And there's also Deep-Prep 1, if anyone was wondering, but that's mostly a moisturizer. At Lehman, I took exercise physiology, and they brought up concepts of the agonist and antagonist muscles. So an example, if I'm flexing right here, this would be the agonist muscle, my bicep, and then the antagonist would be my tricep, right? Having both trained properly is important with an ACL injury, because you can't just have really big quadriceps and no strength in your hamstrings and expect to go back to play with an ACL injury. That's just not going to happen. Both are very important with loading. The muscles are loaded properly. If the muscles are loaded properly, the ACL injury is not going to be much of an issue for them, as long as they get the right treatment. If they can keep the same strength ratio of both quadricep and hamstring, it's going to help them move along the treatment, move along the rehab much more quicker, as opposed to not having done any type of training there. In my opinion, ACL injuries are the bane of every athlete involved in high-impact rotational landing sports, and knowing more about them is just going to help the athletes maybe try to prevent an ACL injury from happening for the athlete. All right, soccer, football, basketball, these are all the sports that we see that causes these injuries to happen in the first place. And at my time at the internship, that was more often than not something that was the sport they were playing. That the kid came in, they messed it up. Now they have to go do treatment for 3 months of physical therapy. And while obviously they're not going to be very happy about it, it's going to help them in the long run, because you don't want a bum knee in the future. It's just not going to be fun. I can promise you that. And all those tests I saw, it just really goes to show that they do care. They want to see you get better. And it's not that there's some over-glorified personal trainer. What the physical therapist is doing is trying to make sure that your knee doesn't give out on you, doing something that you love. All right? And so I just want to say that's the end of my presentation. Thank you.